Copyright University of Auckland, all rights reserved. The content and delivery of lectures in this course are protected by copyright. Material belonging to others may have been used in these lectures and copied by and solely for the educational purposes of the university under licence. You may record the lectures for the purposes of private study or research, but you may not sell, alter or further reproduce or distribute any part of these lectures to any other person. Failure to comply with the terms of this warning may expose you to legal action for copyright infringement by the copyright owner and/or disciplinary action by the university.
So kia ora tātou, welcome everybody to this month's Tōmaiora seminar. It's with great delight that I invite Sonia to come and speak to you today. I've known Sonia a long time, no te Arawa, no Tainui hoki, in her role as clinical leader, nurse leader down at the Bay of Plenty, and more recently as a student of ours within Tōmaiora, where she completed her Masters and got a very high grade, I should just add. We were talking about potential people, and we had a really fabulous talk last month about cultural safety, but for me it did come from a very GP or medical centric point of view, so I thought it would be great to open it up and just hear about what the experiences of nurses are working in the space of health equity and cultural safety. So welcome Sonia, thank you so much for making the trip up from Rotorua to come and speak with us today.
Kia ora tātai, he uri tēnei o te Arawa me Tainui, ko Ngāti Whakaue, ko Tūhourangi Ngāti Wāhiao, me Ngāti Pikiao ngā iwi, huri noa ki tōku pāpa, ko Ngāti Pikiao, ko Ngāti Mahanga, me Ngāti Tipa ngā iwi. No Rotorua hau, kei reira a hau e noho ana. I te tuatahi, me mihi ka tika ki a koe mā tere. Nau e karanga mai ki a hau, and huri noa ki te mana whenua ko Ngāti Whātua. Kia ora. So this presentation is taken from my master's thesis, and it's looking at senior nurses' understanding of health equity. And so just want to kind of start off by saying if at any time through the presentation that you want to kind of stop and have a kōrero about anything that comes up, please feel free. The question that I arrived at around senior nurses' understanding of health equity was to do with sitting in different health leadership hui and thinking to myself, health equity kept coming up, and I thought, well, actually, what do we know about health equity? Because we don't look at the definition of it, we just talk about it. What do we know about it, and more importantly, what do senior nurses know about it? And are we in the same waka? And so that kind of got me thinking about actually, need to dive into it and look at it further and really pull it to pieces, and then find out actually what is our baseline knowledge. What do we know? We're 54,000 of the health workforce, so we're the largest regulated workforce in the country, and so it's really important that we have a really good understanding. We're all singing from the same song sheet. And so as I kind of thought this through and mulled over it, I thought actually need to take the slice, or the senior nurses in the first instance, because of the position that we hold and the influence that we have over other nurses and the environment that nurses are working in. So that's how I landed on senior nurses' understanding of health equity. And I just want to start with my cousin. And so this is Tāle Roimata Morrison, and so in August 2017 she was diagnosed with cervical cancer, and in June 2018 I was at her tangi and she'd passed away, and she was only 43 years old. And so there's two ways of looking at this, and the first lens that we could look through is the one that the health system would use to describe her. So she would have been hard to reach, DNA appointments, all there's the lens that we know, her whānau, her hapu and iwi. And so Tālei was formidable. She's a formidable kapahaka exponent. She comes from a really big family in Rotorua. She's well connected. She's master's qualified, first class honours, and she was renowned for her prowess and her mātauranga and all these things. But one thing that I took away from her tangihanga, and it resonates like boombox loud, is that she said, nothing about the health system spoke to me. Nothing. So she didn't go and get that cervical smear because it just didn't resonate. So if we use the argument around, health literacy or access and things like that, well, actually Tālei defied all those sorts of discussion, all that kōrero that we like to use in the health system. And so instead of conserving her energy when she was diagnosed, like her mother, her professor mother, I might add, told her to do, she drew on her mātauranga Māori, her kaupapa Māori, her networks that were extensive across the motu, and she mobilised Me Your Mea campaign. And so at her tangihanga also, with all the iwi from across the motu, so top of the North Island right down to the South Island, they come and they spoke about her. They spoke about Me Your Mea campaign, and we had kaumātua, we had kui, we had everybody talking about Smear Your Mea. So she managed, through what she knows, or through her normal worldview, she managed to penetrate those areas that normally health promotion cannot touch and does not touch. And so our evaluation around whether the impact of her campaign in that short time was credible or not can speak for itself. And so that was her tangi. She drew thousands. And so this also speaks to me in terms of, what health equity is. So I keep this at the back of my mind all the time, or at the forefront actually. And so when we're talking about health equity, or the definition of it, so in the different health hui or leadership hui that we have, and the policies that we've got, are we referring to the same definition? So are we talking about differences that are unfair, unjust, and avoidable? And so this thesis study also reminds me of the importance of the Braithman's, coupled with Braithman's definition around populations that are exposed to persistent systemic discrimination. As we walk through this presentation, you'll see why coupling the first definition, so unfair, unjust and avoidable, with persistent systemic discrimination is important, because it gives us the focus back on the system or the structure. And so, fundamentally, I just want to pick up on this too, the health equity gaze is predicated on the principles of social justice and is firmly focused on the root causes of inequity. Okay, so picking up on a well-used quality improvement quote by Don Berwick, every system is perfectly designed to get the results it can consistently achieve. And so we know that our health system has got dire results, and so again it takes us back to the system. And so the middle picture, if we're thinking about Tālei's legacy, she clearly did not see the system was for her. I just want to use another example which I thought was quite poignant, and this is my 9-year-old daughter with the pukana eyes in the middle. Her name's Mai, and so at my graduation, who's here for? Not yet. At my graduation in the town, at the town hall in Auckland, she came along to it, and I thought, actually, it's really important, because she needs to see that one day she's going to graduate at university. Her mother's done it, so she's going to think in her mind, well, if she can do it, I can do it. And so, well thought out. I thought, well, I won't be Sonia Hawkins, I'll be Sonia Rapana, because that actually, Sonia TePani Rapana, because that gives clear verbal indication that, she's Māori, she's coming up. So I thought, yep, got that covered off. Anyway, so walk up to the steps, Sonia TePani Rapana. I was like, that didn't work. How did it? Anyway, my father gets up and goes, Arawa, yeah. So my father never says anything, and away he went. He did this big hug, and I thought, oh, he's either really proud or he's really peed off because somebody's just strangulated his name. Anyway, at the end of it, so at the graduation, it's in the town hall and this procession, and they're kind of marching up, and they've got piano, and so this girl goes to kura kaupapa, and she's been to kohanga reo, and so in her world, it's very normal to have a reflection back on what she is and what she knows and what's normal for her. And so she looks at YouTube and the people that she watches all day, every day if she could, kai tātaki wāhine leaders. So they're kapahaka leaders from the high schools, and so we have to go to countdown and, look at these girls that are there, because they're her role models. And that's what she looks up to, and so that those high school students. And then at the end of my graduation, I went to go and see my whānau that were there, and she goes, oh, mama, he wāhi tēnei mō ngā Pākehā nera. So she just thought that was just for Pākehā people and me, and so to her, that wasn't even a place where she might like to go, because nothing about that experience spoke to her. So I thought, oh, awesome, in a couple of hours you've just summed up one of my chapters. Okay, so if we don't get health equity right, and we're using all sorts of definitions, and we're not using them in the right way that we're meant to be doing, then we're going to get all these things. Ineffectual policy development. We're not going to be developing policy that's going to hit the mark and disrupt inequities. We're going to get misdirected resources, keep pouring money into to things that aren't going to work. Unclear accountabilities. People don't see whether they sit in terms of the responsibility for health equity. So if it's system, it's us, it's the system. And we keep perpetuating the status quo. And as I move through this presentation, then you'll see how these come to life. Okay, so just touching on the tenets of health equity in Aotearoa. So, health policy. Health equity is determined by health policy, so it strongly refutes the notion of personal responsibility. Okay, so just using the example of Tale's legacy, the system takes us back to the system. We know that there's stark differences among populations, and some populations get a lot out of the health system and they're advantaged by the health system, and other populations are severely disadvantaged. The equities in health are heavily weighted by political, social and economic drivers. It's very hard to be healthy if you're up against the political, social and economic drivers, which we'll also touch on as we go through. And where you live, work, grow and age health equity, where you live, work, play matters. So just thinking about Michael Marmot's report around, so if you live in Rotorua, for example, in Limor, it matters. And if you live in Fordlands, which is an area of high deprivation, then you're not going to get the same access to services as what you do in affluent areas. And of course, prevailing inequities for Māori is a breach of human rights, and it takes us back to the Treaty of Waitangi. I don't know why I got this stuck on that. Sorry. Good. So this thesis was underpinned by a kaupapa Māori methodology. And just as a note, so when we're doing postgraduate study, when I was doing postgraduate study and did the research paper, we touched on this slightly. But can I say that it is so important that we have access to kaupapa Māori methodology teaching? We need to know this, because when I went looking for kaupapa Māori methodology or research, it was far and few between, and so how can we make it more accessible? And so we need to be getting more nurses undertaking this type of research. And the reason, and so what kaupapa Māori methodology does is it's distinctly Māori, and it validates and affirms our Māori worldview, so it's very normal. It doesn't require justification, translation, and we normalise tikanga reo kawa. So for example, when I sent out my information sheets or inviting participants to take place, then I shared my pepeha, so it was very normal that I was connecting on a different way, in a way that is consistent with my worldview, my beliefs, and also when I interviewed nurses, then we connected on a different level too. So one participant, for example, wanted to know about me, where I'm from, who my whānau are, and all those sort of connectivities, building that trust, whakawhanaungatanga, and then we started off with the interview. So it normalises the research process. It critiques Western hegemony. So, what is the norm? Where is the power? Who holds that locus of power and control? And also, kaupapa Māori is transformative. So yes, we're collecting information, yes, we're doing research, but we're also doing it with the view that we're going to do something about it, and it's going to transform and disrupt inequities for Māori in a way that we understand it in our way, and that's consistent with our worldview, our norms. This is probably a good example that kaupapa Māori isn't homogenous, that we're traditional, we're contemporary, we're diverse, we're not a homogenous people. And I also use qualitative, so it was interviews with senior nurses and thematic analysis to analyse the interviews, the thesis findings. I just want to add too that the research was Māori-led. So my supervisor was Dr. Donna Cormack, my mentor was Dr. Mihi Rātima, and I had a tikanga advisor, Ana Hahini. So he captures a lot of our stories in Te Arawa, and teaches Te Reo Māori. And so he was really supportive actually in helping me kind of unpack some of this, taking me back to what health meant for us in Te Arawa, so understanding where I am and who I am, and then kind of, building that confidence before engaging outwards. And also, so from a nursing point of view, I had Marg Broodcorn, Naira Haka, and also Helen Pocknell, who nurses in the room, I'm sure, will be familiar with. Okay. Right, so had 9 awesome senior nurse participants, and forever grateful for their contribution to this study. They're willing to say, very passionate, as I went through the interviews, very passionate, very committed, and they were very open about what they shared with me, both on a professional and personal level. And so using Nursing Council New Zealand definition of what senior nurses, they needed to have a current APC, annual practicing certificate, at least 5 years post-registration in part-time or full-time employment. And so 8 senior RNs come forward and 1 nurse practitioner. And so if I just kind of talk about senior nursing leadership and using the definition of Lakes District Health Board PDRP program, senior nurses demonstrate nursing leadership through broad problem solving and analytical skills in relation to nursing standards at service, organisational and national level. They're utilised in an expert and advisory capacity for extensive nursing experience and knowledge. work through, or we mentor other nurses through change processes and introduce nursing initiatives which are evidence-based and quality focused to improve nursing standards, practice, enhance the service provided. The change process incorporates partnership with Māori and other client groups and the health team. And there's evidence of application of learning aid from postgraduate or post-registration education to advance our own practice and our nursing role. And we actively participate in professional groups to advance nursing practice. So there's a whole lot of responsibility in that, and our reach is wide. So we're expected as senior nurses to feed in at every level of the health system, which further bolstered my rationale for focusing in the first instance on us, or on senior nurses. Okay, so I'm going to go through and take out that I've gone through and taken out insights that my colleagues shared around four themes. And so, kaupapa Māori methodology, which enabled me to take the heaviness of these findings and turn them into a whakatauki to provide that transformational space, right? Because it's heavy and it's sad, and it was quite difficult to kind of grapple with. And so I was really lucky because my tikanga advisor, Anaha, he is married to Wharehuia Milroy's moko, and so he's a real exponent. And so I'm talking about all these different findings and, trying to process them through. How do we transform it? And he goes, oh, hang on, I'll just ring up my kuros. I'll go on then, that's awesome. But when we talked through, actually, this is a cry out, a karanga to us as nurses, and it's about humility and the understanding the position of power that we occupy, and understanding that when we're working with people that we need to be highly critical of what our own worldview is, our own beliefs, and be able to provide safe care for the people that are entrusting us with their lives. Okay? And so this is what it talks about. It means whakaiti te whare o te whakaro nui, humble ourselves and draw on cultural safety to kind of remind us that actually this is the position that we occupied. So the sub-themes for this one was around racism, the big R word, privilege discourse, bias and stereotypes, and cultural safety. Okay. I'm still going to read it even though I know that you're reading it. Okay. So we know racism is a determinant of health and a root cause of inequities, and it contributes to poor health outcomes. And so these insights kind of take two angles, really. And the first one was from a senior nurse. And so if we're thinking about disrupting the structure and privileging the voice of people that we're trying to attract into the system, then we need to make sure that the people in the system have the confidence and have the power, I guess, to put forward what we need to be hearing. So the first one was around the nurse shared. I kind of learnt some of that stuff through university around institutional bias and institutional racism. I almost felt like every time I tried to talk about that, I was the only one in my class that would talk about it. I often felt quite isolated to talk about that amongst the rest of my colleagues. It's probably still like that now. The only time I did feel safe to talk about that is with my own Māori colleagues. And so this kind of illuminates a couple of things. First, I kind of learnt some of that stuff at university, so we're not openly talking about this. Every time that she tries to talk about it, then she feels diminished, disempowered. And the only time she can talk openly about it is when she's with other Māori colleagues. So other Māori colleagues are also experiencing the same that she is experiencing. The second insight is around how how Māori were made to feel, or a nurse's observation of, as she was kind of advocating for this person, how he was made to feel in our system. So a patient went to the hospital every day for treatment, and he had been receiving fantastic clinical, technical care, but poor care. He's lost a lot of weight, he's really quiet, and he's not normally quiet. He's a very smart man. He's been working in the health system for a lot of years. They've treated him as if they haven't treated him as if he's a smart person. They've been treating him like he's a silly person, like he's a Māori with no idea. And so, if we look at the definition of racism, and I'm drawing on, for the purposes of this study, I've drawn on Kamara Jones' definition, that institutionalised racism is differential access to power, opportunities and resources, and it's categorising and assigning differential value. So who's getting access to the healthcare services, and how are they getting access to the healthcare services? Personally mediated racism is prejudice, discrimination, assumptions about abilities, behaviours, motives and intentions, and the third level of internalised racism, where where we look at attachment to the logic and reasoning of the dominant group, subscribing to the notion of ethnic inferiority. And so, this clearly shows that there's work that needs to be done around having these discussions and deconstructing some of the barriers that there are out there in terms of racism. And I understand now it's a hot topic too, so hopefully that will give us, give us greater rationale, I guess, for having those open discussions and not sweeping them under the carpet. Okay. Is everyone feeling it? Any questions? Yes. Please. Oh no, sorry. 4 Māori, 5 non-Māori. Yeah. Yeah. Any other questions? No. Okay, so I'll read the definition of privileged discourse, okay? So privilege is understood as unmerited access to socio-economic and cultural resources by socially dominant groups. The basis of attainment is attributed to homogenous cultural and social values coupled with positive representation by media. The advantages are cumulative and create divides between groups of people. Entitlements are voluntary acquired and not always consciously understood. So if we use the example of Tāle and probably Mai, then you know that actually that their worldview, that normal, their norms are not the same as what they see in the health system or the education system, kind of. And so, my nursing colleague shared that there's this feeling of it's unfair, that more resource, go into one group rather than another. They don't see the fairness in that. Everyone should get the same amount of resource regardless, and they struggle with understanding the whole. You need unequal funding to get equal outcomes. They really struggle with that. It's a sense of it's unfair, so I can honestly say, couldn't honestly say whether that translates into change, a difference in how they treat people or outcomes, or whether it's just grumblings in the tea room, or whatever. I would hope it doesn't affect the way they work. And as I said earlier, many nurses do as they bid, but don't necessarily agree with what they're doing. That sense of unfair is that one group gets more than another. We all pay taxes. They don't. Our taxes are going to that, and we don't get this. And a second nurse that was hospital-based shared that through her observations, she thinks that Māori probably do better because we tend to concentrate them and they tend to verbalise more actually about what they need, whereas other nationalities such as the Asian and sometimes European, they don't really verbalise what they want or what they think they need. Maybe it's better for Māori than it is for others to a degree. Just that they don't think that they're entitled to anything, whereas I think Māori are more aware of what they are entitled to these days. Said no Māori research ever. I'd like to add to that. Yeah, well, I mean, yeah, no, absolutely. I absolutely think, you know, it gives us, and the other point to note about this nurse is she was master's qualified, so she'd gone through a master's pathway without any exposure to cultural safety, health equity, you know, all the definition for that matter. So when we're thinking about actually, do our senior tools, or are they given the kite that they should be given, then this would suggest that actually, no, we need to do some work around privileged discourse. 1, this is what it is. 2, this is what our system is. And 3, it's real and we need to do something about it. Bias and stereotypes, which we've kind of gone over in terms of the definition. But just to add to that, implicit bias is a natural human resource, which is involuntarily activated. It informs our understanding, judgment, attitude, action or inaction. It relates to health equity as it helps determine how people in need of health care are treated or not treated. So what our nurses said, what my colleagues said were, to be able to access GP appointments, they don't necessarily get the same access to special care appointments or diagnostic checking, or the same interventions are not offered to Māori as they might be to others. And that's because people have their own filters. Like specialists and doctors might apply their own filter to people and decide that already they won't turn up for an appointment, so they won't give it to them. They won't do very well with these resources if I give them to them, so they're making these judgments. They don't look like the kind of people who might do well with an opportunity if the opportunity is on offer. So nurses' observation is that we kind of use our subjectivity, our implicit bias to determine, as the definition tells us, who's going to get access to care and who doesn't. Another insight is provided by a nurse was, yes, you see it, that people are very articulate, well brought up, used to talking with adults and that kind of thing. They tend to kind of dominate the conversation and get treated with more respect, I think, than people who don't have anything. You know, if you go into somewhere and you look bedraggled, well, that's how you get treated. And so again, you know, just highlighting that actually implicit bias is real and it's raw and it's determining who gets care and who doesn't. Despite the fact that nursing has cultural safety, and we have had it since the 1980s, and you know, we pushed out, or Māori nursing leadership was a platform for pushing out cultural safety, and there were very clear reasons why we needed to demonstrate that we're culturally safe, and the practice of it says something contrary. So when one of the nurses said, actually, working in the hospital as a young nurse, we just treated everyone the same, and it was very task-oriented training. So if I was the junior nurse doing the bedpan round, it didn't matter who was sitting in the bed. They got given a bedpan or given a mouthwash or had their back rubbed. So I think in those days, the way we nursed didn't allow space for personal feelings about race and ethnicity to colour what we did. We just did it by rote. And so, again, bringing us back to, well, whose norm was that, you know? And so there's the perception that, well, we actually just, and you still hear it, you'd hear it too in the forums that you go to, you know, we're all the same, I treat everyone exactly the same way. Actually, that's not okay. And for some people, they choose not to engage because the way that we treat them, which is our norm, is not as disrespectful to them in that norm. And so cultural safety gave us a really strong platform to disrupt that and not to treat people like we would like to be treated, that actually we treat them according to how they want to be treated. And so the other insight around cultural safety was sometimes you see people's personal views versus their clash between people's personal views and their personal knowledge, skills and experience and their professional obligations. So just because they're professionally obligated, their personal views are still clouding the way we implement cultural safety into practice. And quite often, if people feel different to personal views, that can often be a barrier. So the second theme that nurses talked about was around, and I've used the whakatau ki mā te wai Māori anaki ora ai te kiwai. So if the environment's not right, then we're not going to, the freshwater crayfish is not going to live. And so nurses talked about actually the environment, the health system, and the way it's designed and the way it's funded, and the political priorities or the drivers are problematic. So it's going to be detrimental to health equity. And so the first example is, so when we do develop up these targeted programs, so the CVRA assessment and the DARS assessment, nurses shared that actually this is what they were seeing happened. So the first one is about this cardiovascular risk assessment program. So one way PHO dealt with it, or provider dealt with it, was it might be like we can get $200 if we see so many Māori patients for this. So they will go through the computer and set up a system to pull all the information so that we can do this, and we've done 1,000 of those, yes, and that's great. They will employ someone to do that and not actually see the patient. And so it's false. Whereas what needs to be is to be strict. You need to see the patient for this amount of time, and whether it's a home visit or clinic, things are not done by not seeing them. And I think because in the past you could do a virtual CVR. You don't see them, looks good on the stats, and you've done all these CVRs and you see these patients, so who benefits? The patients not, unless you follow them up. But I just think that it's greed thousands of dollars. So it talks about here the perverse incentives of programs and what might be happening. People aren't actually getting seen, and providers are finding other ways to meet the targets, but also benefit from the financial incentives that have been offered. And so the second insight is around the Cornerstone program. So we have requirements. The Cornerstone program, as you know, have requirements around Māori. And so this nurse shared that actually we deliver the work and it's sort of blah, blah, blah. They go, we're doing the Māori thing again. They just do it because they've got to get Cornerstone, and they're doing it because they have to, not because and they're not doing it because they now understand it, and the practice didn't actually change. So we're doing things without having there's no meaningful substance to what we're doing. So this talks about the systems and its design, and the first example is around a nurse consultation, and she talked about the DARS program, so the annual diabetes review program. And so her observations were time and health professionals that want to offer and some that don't. So if they're not getting anything out of it, if they're seeing someone, they're not getting paid for it, they are probably going to say actually they will have to come back next time, and we all know that the patient can't afford to pay, so that person is not going to come back, or they will come back and they'll get a bigger debt on their account, which is pretty disheartening for them because they know they need to be seen, but they also know that they're getting a burden at the same. So this talks about when nurses are delivering the diabetes annual review check, and they're bringing people in, so people are reaching in, coming to see, and the nurse goes through, retinal screening, podiatry, healthy eating, and all those things, and then they need a doctor to see that patient. And so what this nurse says is actually we're not necessarily, we're not maximising the time that person's coming in. We're saying actually the appointment's getting paid for here, and they'll have to come back and pay again. And they don't come back. And so the second insight talks about actually if we're trying to disrupt the structure and we're trying to get more Māori in, and that actually we need to think about how we're designing the program. So she said they'll design services Māori that actually come through a lens of a perspective that's theirs. So the architects of the program, or the people developing up the program, aren't the people that are going to be using the program. So they'll come up with a model like healthcare homes, which is a mainstream Pākehā type concept where all patients need to be attached to a healthcare home or a general practice, and all their services delivered to that general practice. So we have to get all the Māori people to go to the general practice to access that. rather than design systems around the needs of patients, and then they'll have conversations, well, why do you think Māori people won't come to the practice? So they then tend to blame the patient rather looking at the way they're designing the systems and their thinking. So I think it's a huge barrier and health politics. So again, going back to our, what Tale said, that the system didn't talk to her. And when she went to go and mobilise an entire health promotion program, then she got quite a different response. Is everybody still with me? Not having a sleep? Nurses also recognise that the health funding and the barriers to health equity through how we're funded. So the first nurse talked about actually in her area, you just needed to have 2 chronic conditions to have access into and 2 admissions to hospital in the last 6 months, or something like that with their condition. But they don't have like an ethnicity group, and or doesn't look at financial or demographics. So when we're thinking about that, we've got fiscal constraints, and that we need to be diligent with how we're resourcing or using Vote Health. Then if you're kind of opening it up to, if you're not clear about how we're going to about resourcing of or allocating resource, then we end up with this. Also, what nurses talked about, actually Māori providers might get a level of funding, say 100k, and then you might get a mainstream provider that gets 100k to deliver the same care, but the people they are delivering the care to have different needs. That 100k might service the worried well and getting better, and she talked about the area of least deprivation, and at the same time the 100k is applied to Māori provider that's working in an area of high deprivation, where the patients have more barriers to accessing health care, transport, childcare, and not enough financial resources. So that can be just simple things like being able to pay for their prescriptions, but they use the same formula to apply the same service. And so in Rotorua, for example, you've got Fordlands, and you've got a 40-minute walk to the GP, and there's 7 that kind of service that area. And I did a comparison with Maryvale, and so Maryvale's got 5-minute walk. So most affluent community in the country, 5-minute walk to the general practice, and there's something like 40-something GPs. And so, how are we thinking about access to resources? Nurses are saying that we don't. This is recognising, nurses recognising that who you got in government makes a difference, and it comes from the top. And so she shared, so who we vote for matters, and what the political priorities matters in terms of health equity. So I think who you've got in government makes a difference. It's that really affects as it comes from the top, and so governments have to understand inequity, and they have to, their policies and their legislation, their funding, all that has to account for and make it possible for people who are trying to redress inequity to actually do something about it, and that's very, very complicated. So we understand as nurses the macro implications in terms of political drivers. The second insight is, well, I think a lot of those things cost too much money. The wheels of the government work quite slow, and I know, for instance, they're moving into government at the moment to try and get more things working across the sector, but until Nia Glassy or Cartwright inquiry or something like that, things often don't get acted on and stuff sits. So this nurse talked about actually whatever the political priority is, and that's what the government acts on, and the changeability in terms of what we focus on. I think I'm kind of... Okay, so this theme talked about the whakatauki nau te raudo, nāku te raudo ka oro ai te iwi, so we all have to work together. And so the sub-themes around this I'll go into. And so realising the nurse potential. So we talk about in our profession that we must work at the top end of our scope of practice. So the nurse shared, we have a good session and then they go see the doctor. while I understand and I'm quite comfortable that my knowledge base is adequate to be adjusting their medications when it comes to diabetes and learning hypertension, how to titrate their doses, they go to their doctor and all is repeated again. And the choices I have made, which have been guided by evidence-based practice, so the primary healthcare guidelines is superseded by something else. It has quite an impact on your confidence level for one. It is incredibly frustrating because you've spent the time with that patient, you've developed a bit of a relationship, and it all becomes null and void when they see the doctor. So I know that if that patients need to see the general practitioner, I'm the first to say that. So she was talking about actually if I need to refer, I'll do it and I'll do it quickly. Lots of patients don't, so that's just an example of undermining of nurse care. So we need to do some work around actually, we've got limited resources. If we've got nurses, encouraging nurses to work at the top end of the scope, then we have to do something in terms of the healthcare team to enable that. And at the moment, nurses are saying it's not necessarily the case. I'm feeling really guilty that I'm flicking through like 30,000 slides with you. And so education matters. And so what the first insight was offered by a nurse who had embarked on post-grad education. And so it wasn't until she had studied a long-term conditions paper that everything started to make sense around health equity. And so for us, what are we doing in terms of normalising those teachings? So she talked about coming into primary care. Definitely primary care has really helped me to open my eyes to the situations that are going on. I did the long-term conditions paper a few years back, and that was when I started to think about it, consciously thinking about it when I did that paper. It might have been when we did the quality part of the paper that we had to do little audits, and it made me think, hang on, there's something amiss here. That was a long time of me being a nurse before I started to see that there are things there. Looking at nurses I trained with and worked with, there's not a big turnover. I think that they're still stuck in those entrenched ideas. They just haven't moved past it. Maybe the ones doing postgraduate papers are forced into thinking, but not forced, but confronted with that. I think they just happily sail on. We do as we are bid, but I think there's a lot of resentment and a misunderstanding around health equity and stuff. And so we've got a proportion of our workforce that still don't understand health equity, don't see the importance of it, and so what do we do about it in terms of what we're offering, within our education system if they're doing postgraduate, but we can't assure it as well in terms of the individual organisations where nurses are going to go to for education around these things. And so the second nurse kind of validates that, and she talks about if you were to do an audit of how many staff that say actually did cultural safety and treaty training at the start of induction, there'd probably, I'd say half that actually did it. And then if you were to ask them how long they've been there, and if they've been there longer than 5 years, and have they done an update, none of them would have. It's just not seen as a priority. So, within our individual organisations, what are we doing in terms of supporting around cultural safety and treaty training? And we know that when we apply for our annual practicing certificate and we say, yes, we're competent, yes, we're culturally competent, I mean, that sometimes could be the end, that could be it, So this kind of really highlights, the need for us to start thinking about education and how we're supporting nurses around health equity. This here talks about workforce and leadership. And so the nurse was, working in this area, and she shared that almost all, probably 85% of their staff, the provider that serviced that area, didn't come from that area. The staff come from areas of high deprivation, yet they were making decisions for people within the community that she lived, and they were non-Māori. So I was asking them to account for how many times they shop in this area. Do their kids participate in sports in that area? Do they have friends in that area? Do they have Māori friends? What level of communication do they have in the community? or those particular people, and most of the 85% staff didn't shop there, didn't know the people, didn't come from there, didn't have any idea really about the lifestyle or the challenges that people have. 7 years on, you walk up the street, and now all the shops are shut, the social challenges are really enormous, and there's still staff in the practice don't have much idea about the pressures of the town and why health issue and the health issues and the type of health issues that are being experienced by people and the impacts that are occurring in that town. And so that really speaks for itself in terms of, some of the things we're doing to try and recruit from different communities and have them go back into those communities. They live, they breathe it, they know it. And so the nurse is talking about actually predominantly it's people that don't understand that community kind of go back home, and her observation is that they're removed from it. And so while we like to think this sub-theme talks about our connectivity to each other, and that while we're 54,000, that actually we're not very connected to each other at all, but we could be, and we could be a critical mass kind of moving in the same direction. But this nurse shared that collectively, yep, we could be a big change machine. I think part of the problem is nurses are very disconnected themselves from each other, so primary health could have a reasonably strong network with each other, but we don't have strong networks for secondary care nurses. So that would be a definite enabler of health equity. There's a connection between groups of nurses, so we don't really know each other in different communities. We don't know, there's a gap between kind of, like, we talk seamless care, but we don't know each other, is what this nurse was saying. We don't connect NGO, primary, secondary, community, education, all the different areas that we work in, we don't connect up. Okay, moving to the end. Are there any questions? Comments? Anything? No. I'm on the home straight anyway. And so I really like this whakatauki because it's Princess Tipa, and she talks about actually we can do it if we all do it together. If one person or one area does it on their own, it's fraught. But if we all come together and push forward in terms of health equity, achieving health equity and disrupting inequity, then we can. So she gives us that transformational hope. And she's done it because she moved the whole iwi from one rohe to another to save us, which is why I ended up in Rotorua. My father didn't meet my mother. So it works. Okay, meaningful ways of working with communities. So we kind of touched on this a little bit on the previous theme. So for policymakers, program developers, this nurse shared that because I'll read it actually, because even though they didn't have a community services card, they might have been entitled to it. I feel it, but they never really made it to WINS to sign up for it because they didn't have a car or they couldn't get there, or money for petrol, so they probably were entitled to the program, but they never actually ever got it, so why should they miss out? So the unintended consequences or understanding that actually when we're developing up a program, this is the reality for this community, and that we do everything that we can to pull down the barriers so we've got easy access to those to care. Otherwise, they just don't engage, and we lose. The resources are erroneously allocated, I guess. And the second one was it's ignorance. They don't try hard enough because I know there is a need. Some of the ones that are contract people, they need to know the key people, because I've spoken to the specialist nurse that went out to this community, and she said there's never anyone home. I said, but you need to get in touch with this person, so a key community worker there, and you need to get in touch with the shop person, and you need to talk to them. She said, oh, who are they? So we're sending people into communities. They don't know the community. They don't feel confident and probably not comfortable in the community. So they go in and then they come straight out, and then we miss the opportunity. And so this sub-theme talks about meeting community needs. And so this practice nurse talked about, being in general practice and not actually knowing what other services were available that she could refer to. And so she talked about, especially to general practice, who do we refer to? Come and tell us your story, tell us how to refer, we need to be doing this, we have these people of need, where do we put them, how do we help? I think as a practice nurse, when you're working with families and you know that you need to know where to refer and programs come up and they go, and I know that nurses and even GPs struggle to keep up with what's out there to know how to refer and where to refer to. So even though we do have programs, we're not necessarily referring to where we need to be, as the take-home message from that. And so, couple more slides to go. And so this nurse talked about being in this small community and about a whānau that was discharged from the hospital, had to drive about 60 minutes home, and they were told, someone's going to come and see you, right? So they didn't know in the secondary services, because we're not connected up, that actually there's no service out in that community that they're getting discharged to. So this nurse shared, so seeing patients with wounds that had healed over, stitches hanging out where the skin had completely gone over, or skin grafts that got majorly infected because they haven't got seen and they have gone septic, just where it shouldn't be happening. But I think lack of communication between here and probably they don't know, because they think district nurses get in touch with them and they will go and see them, but they never do. So these whānau are getting discharged, waiting, and nobody turns up, and then, we get complications. And so, again, understanding our referral pathways, our communities that people are going back to and doing something about it. So nurses talked about the importance of, when we're going into homes, when we're working with whānau, that our assessments need to be holistic and they need to be comprehensive. So we don't go in, that's what the nurses said, for one thing. We've got to go in, maximise the time and the whānau time, and then come back, do what we need to do. And so this nurse talked about enablers around health equity, and so they don't just do immunisation, but they do this other program, which is healthy home initiatives, and they help to look at employment options for parents and support the mothers at home, and about the things that they can change. So there's direct education, home education, and so they're in effect they're using the maximum opportunity that they can with that family, which isn't always the case, as we know, for some of these programs. We go and do a little bit and we're back out again. Second to last, so this talks about that when we roll out programs, that we just roll them out, is what the nurse said. So we go, this is really important, it's all developed up, and then, go. But this is what the nurse said about that approach. It was just rolled out as there's funding. I don't think there was a whole lot of discussion. I can't remember the paperwork that came, whether there was a lot of advice or information given about the reasons behind it. It was just like, these women aren't getting their smears done, so we need to give it we need to give free smears. I don't even know whether there was a lot of thought behind the whole program, to be honest. I don't believe there is good communication around what the program is trying to achieve. It was just like, let's do it. There needed to be a lot more background information, and maybe that's why we don't really, or haven't got to a really good place about nurses' understanding of equity problem, because we don't really put enough communication behind it to us understand, and people go, yeah. And so that kind of loops us back to how we started, and it was with Tale's legacy. And so, I had 50 recommendations, whole lot. But, do senior nurses understand health equity? I would argue strongly no. Is there more work to be done around it? I would strongly argue yes, and the work that we do need to be doing needs to go across the levels, at the high level, so the macro, the middle bit, and at front line. So, nō reira, thank you for listening. So sorry, hurt your ears. Tēnā koutou, tēnā koutou, tēnā tātou katoa.
to acknowledge that I gave Sonia not even 5 days to get this talk ready for us today, so I think she deserves a big paki for that, because I thought it was fabulous. Thank you. And before I open it up to everybody else for questions, I found one of your first points quite interesting, and it sort of came about with supervising another Māori nurse with her masters, Lorraine. This idea of being few nurses publishing with a kaupapa Māori methodology, what do you think that's about, and how can we address that as teachers, I think, within, our research?
Yeah, well, when I did the research paper, I think we might have had about 10 minutes on kaupapa Māori research, and so what prompted me to look at kaupapa Māori methodology was because of the readings, the people that whose research I read about. But it's not readily available for us, and it's not taught in nursing curriculum as much as it should be. There's few and far between kind of Māori nurse researchers, so there's a whole lot of confounding factors around that. So, but personally, using this kaupapa Māori methodology is empowering, because it that normalises what worldview and things like that, and it validates it and all those things that but yeah, so I think making it readily accessible, and that's just one university. I don't know what's happening across the rest of the universities, and whether we're teaching kaupapa Māori methodology as part of research methodologies. So in Lakes DHB, the courses that are prioritised for our population are clinical assessment and reasoning and nursing advanced care, I think. And I think they started to fund long-term conditions, which has a health equity component, but that's not kaupapa Māori methodology. You're not learning about it, and we're 30% of the population. So, it's just structure stuff again,
Karen?
But I wondered if you had done it with junior nurses, would it potentially be better? Do you think?
Because they're exposed to curriculum.
Better, and they don't have the "oh, but back in my day" thing?
That's why I'm doing my PhD. And so my PhD is looking at racial and ethnic bias among nurses, so looking at pre and post assessment curriculum exposure. Yeah, so nurses are coming through, first year students and postgraduate nurses, yeah. So I'll tell you in 4 years.
Back in 3 years, everybody.
Yeah.
Do we have any questions on this side?
Can you undertake research using a kaupapa Māori methodology for long?
So my understanding is that kaupapa Māori research is led out by Māori, but wouldn't you be better to answer that?
I don't mind anything.
Yeah, please.
It's a contested space, and so some people would say no, it has to be Māori led by Māori only for Māori, but others of us, perhaps, and I'd probably put myself in that camp, would say I have supervised non-Māori to do kaupapa Māori research, but to be consistent with the principles and values and not to claim or appropriate the notion that they are definitely doing kaupapa Māori, because I think we need to acknowledge the contested space. But if you can align the research to the principles associated with kaupapa Māori without having to claim that it is
I know Sonia has to travel back to Rotorua on a plane this afternoon, so grab her quickly. But before she goes,
Oh, thanks. Yeah, it's